Hi friends, I am Dr. Harmeet Goel, Obs Gynae faculty. Today I am taking up Obs Gynae High Yield MCQs discussion for the upcoming exam. So I have kept a number of questions, and so many questions are from the previous FMGE exam questions. Some of them are PG question, some of the questions I have made myself. So it is really going to be a very fruitful session, and some of the questions are expected from today's session. So let us just start with today's discussion. An intern conducts a delivery. Immediately after delivery, mother experiences breathlessness, hypotension, tachycardia, and she collapses. Per vaginum examination is normal. There is no excessive blood loss. Most probable diagnosis. Friends, students, you can keep on writing in the chat box for your answers. Okay, this has been a favorite question of INI CET pattern exam, but it has been asked in FMG exam as well. So this is very important question. Sometimes they do not ask from postpartum hemorrhage, but they ask from other topics of third stage of labor. What are the complications? So this is one of the complication. So what do you think should be the correct answer? You could mark in the chat box. I can see Dr. Divya, Dr. Sharvan, Dr. Sain, Nikhil, and WDT. So very correctly, this is amniotic fluid embolism. So this session is going to be very crisp, but very fruitful and to the point discussion. Okay. So PPH occurs when there is excessive blood loss. In the question, they say that there is no excessive blood loss and per vaginum examination is normal. So it cannot be postpartum hemorrhage. DIC never presents like this. Friends, whenever in the question it is written as breathlessness, hypotension, tachycardia and collapses. Okay, and there is usually one more thing, that is cyanosis. This is because of the amniotic fluid embolism, but you have to keep a differential diagnosis of pulmonary embolism as well. So this situation is very life threatening, friends. And one more thing, why it is not acute inversion of uterus? Because in acute inversion it is said that shock is out of proportion of blood loss. Shock is out of proportion of blood loss, and in this question it is not written like this. So the answer is D, amniotic fluid embolism. And mortality, because so many times the clinician is not able to diagnose and patient collapses and she is gone. So mortality from this situation is very high. Now let us move on to the next question. Pelvis associated with persistent occipito-posterior position. Persistent occipito-posterior. Number 1, occipito-posterior is malposition of head. Mind it, it is not malpresentation. Malpresentation means any presentation apart from cephalic. So breech is the most common malpresentation. Transverse lie is the most common malpresentation. Now let me make one diagram. This is ischial spine and I have divided the pelvis into 8 equal parts. Normally if occiput is anterior, this is symphysis pubis, This is LOA position and this side it is ROA. Now in this case occiput is posterior. So occipito-posterior position, the stages of labor are delayed. The stages of labor are delayed, and when there is a mechanism of labor, there is anterior rotation of the head so that occiput lies behind the symphysis pubis and delivery takes place. If there is arrest, this is called as oblique arrest, this is oblique arrest, or there is direct arrest, or this occiput moves and get arrested at the level of ischial spine, that is called as deep transverse arrest. So whenever interischial diameter is less than 10 centimeter, according to Williams it is 10 centimeter, according to Datta textbook it is 10.5 centimeter. So whenever the diameter, interischial diameter where internal rotation of fetal head occurs, it is less than 10 centimeter, then occipito-posterior position get arrested in a situation which is called as deep transverse arrest. So deep transverse arrest is most favored in android pelvis. If this is called as male type of pelvis or heart-shaped pelvis, second answer to mark is anthropoid pelvis. Okay. So this is gynecoid pelvis, this is anthropoid pelvis, this is android, and this is platypuloid. This is android where bispinous diameter is shortened, so deep transverse arrest is favored. This is also called as male type of pelvis. This is platypuloid where deep transverse arrest can never occur. This is anthropoid pelvis where the bispinous diameter is shortened. So here also deep transverse arrest can occur. Now which of the following is more common or best answer? Always mark android pelvis for deep transverse arrest. Okay. And what is the management of deep transverse arrest? Is always emergency cesarean section. We cannot predict deep transverse arrest beforehand, but we can always do the pelvic assessment in the antenatal period or in the beginning of labor pains. This is gynecoid pelvis where cavity is circular. So most of the females have a gynecoid pelvis. So this is normal pelvis. So where occipito-posterior position occurs, where android or anthropoid pelvis, one answer to mark, it is android. So here deep transverse arrest occurs, management is cesarean section, and in olden times there was a forceps which was used to rotate the fetal head and extract. This is called as Keeland forceps. So very rare chance they are going to ask, this is outdated forceps. Okay, because high forceps are not applied. Nowadays we only apply the outlet forceps when the fetal head is visible in the perineum. So I hope this question is clear. This is an FMGE exam question. Next, a 37-year-old unmarried female is on OCPs. She is sexually active. Okay, unmarried but sexually active. She visits her gynecologist for a routine screening, and her mother had breast cancer at 55. Her sister had ovarian cancer at 40. So there is history of breast cancer in the mother at the age of 55. At 40 years, there is history of ovarian cancer in the sister. So family history of 2 cancers is present, and number 3, she is nulliparous unmarried female. So tell me which of the following is recommended. Stop oral contraceptive pills because it will increase the risk? No. Oral contraceptive pills protect against ovarian cancer, and our standard textbook Novak Gynecology says that OCPs do not cause the breast cancer. Okay, but second point is whenever there is a family history of breast cancer, very careful and cautious, we usually do not give OCPs. Okay. So what is the answer? Dr. Satyam, Dr. Pandey, Dr. Krishna, Dr. Divya, Dr. Sai, Dr. Sakshi, Dr. Sharvan, Dr. Satyam, Bharadwaj, Divya, all of you are very attentive in marking the answers. So stop OCPs, I am not in favor. What is recommended for her? Is stopping the OCPs going to solve her problem? What is the risk in her? Nulliparity is a risk factor. Breastfeeding, childbearing are protective. Okay. Prophylactic surgery for what? She should remove the breast or she should remove the ovaries? Or have we done any gene testing in her? No. Mammograms every year. But what about the ovary? Tell me one thing where both of the cancer risk can be assessed. This is what is done by genetic testing after we do a genetic counseling. So in the hospitals, there are genetic counselors who do the pedigree analysis and they tell how much is the risk involved. And plus one more thing. After the patient is convinced and she wants a genetic testing, so a blood sample is taken and a gene analysis is to be done. So what is the gene analysis? BRCA1 gene and 2 gene. BRCA1 gene, the defect or the mutations are present in chromosome number 17 and here chromosome number 13. So BRCA gene testing is to be done, and if this defective gene is present and the risk of breast cancer and ovarian cancer is there. Okay. Now according to standard textbook Novak, what is the recommendation if this defective gene is present in the mother and the sister and this female who is unmarried, then what is to be done? The textbook says we have to do after her family is complete, she is not yet married and childbearing has to be done. So she has to be under screening, okay, and after the family is complete, prophylactic bilateral salpingo oophorectomy has to be done, because removing the ovaries, you have almost cut down the source of the ovarian cancer, because ovaries have been taken out and estrogen has been gone down, so that risk of breast cancer is also been reduced. Okay. So I hope it is clear. BRCA1 gene testing, and it is available in most of the centers. Okay. And this is what is recommended. So this is very clear cut answer. There are 3 risk factors present in this female, and mother had breast cancer, sister had ovarian cancer. So we have to do genetic counseling, genetic testing and BRCA1 gene testing. Fine. Is it clear? Yes, we can do mammography, but friends, mammography starts after 40 years. Mammography starts after 40 years. Now, next question, which is incorrect regarding magnesium sulfate pre-eclampsia, eclampsia management? Which is, first of all, we should understand they are asking which is a false statement, or which of the following is a wrong statement regarding magnesium sulfate in pre-eclampsia, eclampsia. I have tried my best to make this test paper for you, because it is high yielding MCQs for upcoming exam. Even those who are going to write the PG exams, this session is really going to be useful, because it is selected questions from the previous PG exams as well as FMG exams, and some of the new questions I have created. So it is going to be complete coverage, Remember friends, out of 300, minimum questions for Obs Gynae are 30 and maximum they can ask 300. Okay. So 10 to 15% paper is Obs Gynae, and this is very scoring subject, and the students, I am taking classes, I have taken the online sessions as well as the face-to-face class in the batch. Students are really doing wonderful in this subject and majority of the students are marking the correct answers. So let us read my question. It has been an anticonvulsant effect onto the cerebral cortex and simultaneously lowers the blood pressure. Magnesium sulfate quietens the uterine activity. This is action is dose dependent. This statement is correct. Maintenance dose is given for 24 hours after delivery or even postpartum convulsions occurs. So the maintenance dose of magnesium sulfate 50% 5 grams is to be given 24 hours of delivery or 24 hours of last convulsion. This statement appears correct. Now the fourth statement, magnesium sulfate is entirely excreted by kidneys. Yes, that is why measuring the urine output, we put a Foley's catheter and urobag, so that whenever we give magnesium sulfate, loading dose, that is 14 gram, 4 gram 20% IV plus 10 gram 50% IM, 5 grams in each buttocks. After 4 hours, we check knee jerk, respiratory rate and urine output. Knee jerk should be present, respiratory should be normal, and urine output should be more than 100 ml in 4 hours or more than 30 ml in 1 hour. So how do you measure the urine output? Is by Foley's catheterization is done and there is a urobag. Okay, so we ask the sister to check for the urine output and tell us how much is the urine output. Okay, if suppose there is no urine output after you have given magnesium sulfate, you have to stop magnesium sulfate and replace it second line anticonvulsant, that is injection phenytoin. Mode of excretion of the magnesium sulfate from the body is kidneys. First sign of magnesium sulfate toxicity. What is the first sign of magnesium sulfate toxicity? Is always disappearance of knee jerk. So there can be, as the magnesium sulfate level rises, the safe therapeutic level is 4 to 7 milliequivalents per liter. If the level rises to 10, there is knee jerk will be absent. If the level rises to 14, then there is respiratory depression. If the level rises to more than 25 milliequivalents per liter, then there is cardiac arrest. Okay, so measuring the magnesium sulfate levels is important. What is the antidote? Antidote of magnesium sulfate is calcium gluconate. It should be given very slowly IV, because if you give it bolus, it can cause cardiac arrest. Which type of cardiac arrest is caused by calcium? Is systolic arrest. And which type of cardiac arrest is caused by potassium? Diastolic arrest. So this also is correct, because it is purely been excreted by kidneys, and hence initial dosing dose, irrespective of the renal function, it is given. Okay, then we go for a maintenance dose, because initially when the patient comes with convulsion, the blood pressure is very high. So there may be decreased urine output or there may be anuria. Okay, so we give a loading dose. So one thing important is that magnesium sulfate do not lower BP, do not lower the blood pressure. If magnesium sulfate lowers the blood pressure, then where is the need? Where is the need for us to give antihypertensive? So with magnesium sulfate, antihypertensive has to be given, and the choice is labetalol because onset of action is fast, and there is, it is very safe drug and there is no teratogenic effect. So remember, magnesium sulfate act as an anticonvulsant, but it only in eclampsia, it is not an anti-epileptic drug. I hope it is clear. All those who are attending the session, Dr. Paras Patel, Dr. N. Kumar, Dr. Vihari, Dr. Shravan, okay, yes. Anti-epileptic of choice with minimum teratogenic effect or a safer anti-epileptic drug is lamotrigine, which they have asked plenty of time. Okay, lamotrigine. Then nowadays there is levetiracetam, safest anti-epileptic drug. Safest anti-epileptic drug, you have to mark levetiracetam. If that's not given, then lamotrigine. All of the following investigations are cost-effective screening tests done routinely in pregnancy except. Now I want you to answer this question. All are cost-effective screening. This is little bit PSM or preventive type of question. What are the tests which we are doing in the antenatal clinic in the pregnant ladies according to Government of India guidelines? So I want, pertaining to this question, are you testing for bacteriuria like urine sample? Yes, this is very much cost effective. Okay. Are you doing screening for diabetes? Yes, it should be done universal screening at first visit in all pregnant ladies. Then second screening can be done between 24 to 28 weeks because at this time insulin resistance is high. So very good chance that you can pick up the diabetes. Nowadays DIPSI criteria is used. Okay. Then VDRL for syphilis is being done routinely in all pregnant ladies. Echo for cardiac causes is not routinely done, and echocardiography for the fetal condition is not a cost effective method. It is costly in comparison to other methods. So answer to this question is echocardiography for cardiac disease. किसकी cardiac disease देख रहे हैं हम? अभी जो इकोकार्डियोग्राफी की बात होती है ये फीटल की कंडीशन है. मैटरनल इकोकार्डियोग्राफी भी करते हैं वंस वी आर सस्पेक्टिंग एनी मैटरनल कार्डियक डिजीज. सो दैट इज नॉट कॉस्ट इफेक्टिव, इट इज अ कॉस्टली इन्वेस्टिगेशन. सो फ्रेंड्स, यूरिन एग्जामिनेशन फॉर albumin sugar or culture is a cost effective method. Screening for gestational diabetes is again cost effective. VDRL for syphilis, this is recommended in the antenatal by the Government of India guidelines, but routinely echo is not being done. Yes, Dr. Nitin Kumar, you are very correct. Fine. So all of you are really marking the correct answers. Okay. Fetal, tell me a condition where fetal echocardiography is recommended. I have just now mentioned one condition. What is that? Yes, VDRL is, friends, very routinely it is done. Fetal echo is done in which condition? Where you suspect congenital heart disease, like maternal diabetes. She has pre-gestational diabetes. So the type of congenital heart disease in the fetus will be VSD, most common, but most specific heart disease in this baby will be TGA, transposition of great vessels. So there fetal echo is being recommended. Next question. A female has previous history of cesarean section. This is previous LSCS and she has prolonged labor. She has prolonged labor and now she has become hypotensive, fall in blood pressure, fetal heart sounds, not heard. Not heard means baby has become dead. Okay? Fetal parts felt very superficially. Friends, whenever there is obstructed labor, once the uterine contraction starts, okay? For example, this was a transverse lie and patient has been referred from some untrained personnel die, okay? And in this transverse lie baby, once the contraction starts, if the baby is not able to come out from the vagina, definitely it is a malpresentation, baby is not going to come out, or it is a broad presentation where the diameter is big, 14 centimeters, mento vertical. So baby will not deliver. These situations land up in obstructed labor and if neglected, it will rupture the uterus. So fetal parts felt very prominent because baby has come out from the uterus and it is fetal parts are felt very closely beneath the abdominal wall. Okay. So this case, it is a condition where uterine rupture has occurred because she is in hypotension and the baby has become dead and fetal parts are felt very, very prominently. Okay. Next question. Which is not included in the diagnosis of preterm labor? Preterm labor is when the labor begins before term, that is less than 37 weeks of pregnancy. With preterm labor, PROM, premature rupture of membranes, is also an associated condition. When cervical dilatation is more than 1 centimeter, do you call it as preterm labor? No. Even in latent phase, this can be a condition. Effacement is 80%. In primary gravida, effacement occurs early. This is again not a condition. Cervix is always central or posterior? No way. Cervix can be anterior also. Okay. But uterine contractions, 4 contractions in 20 minutes, 8 contractions in 60 minutes. This is what is a preterm labor. Fine. Next. Pregnant lady visits antenatal OPD for the first time at 18 weeks. Her fundal height corresponds to 16. Means if I draw a diagram, fundal height at symphysis pubis corresponds to 12 weeks. At umbilicus, you can say 24 weeks. At xiphisternum is 36 weeks. If you divide umbilicus and symphysis pubis space into 2 equal parts, and if the uterus is felt here, this is 16 weeks. Now according to dates, her fundal height should come here, 18 weeks. Okay, fundal height less in the second trimester. Maybe there is oligohydramnios. This is because of renal agenesis. Okay. And fetal anemia, very unlikely, fundal height will not go down. So one important reason for less fundal height is wrong dates. If she is very sure of dates, then you think of oligohydramnios and the cause is fetal renal agenesis. Even anencephaly, the fundal height can be same or it is decreased, but I am going to mark the answer as fetal renal agenesis and oligohydramnios is associated with that. Now this is anencephaly. Write down what do you see on ultrasound. What is it called as? What is it called as on ultrasound? If you see a condition, here the baby is born and this is anencephaly, and I think there was no ultrasound done in the antenatal period and it might be unbooked, unregistered case who has just landed up in the labor room for delivery. So this is just an anencephaly baby. So what do you see on ultrasound? This is an ultrasound image and it shows frog eye sign. So frog eye sign is anencephaly. Even you can pick this anomaly in the first trimester itself. Fine. Now 25-year-old female, para 1 L1, delivered 12 weeks back. So she has a delivery 12 weeks back. History of continuous bleeding per vaginum. Students, when it is 12 weeks already delivery, so it has ruled out secondary PPH because PPH is till 12 weeks. But it is already crossed 12 weeks, so it is not PPH. She has DNC done in some private hospital, but still the bleeding is continuing. In spite of the DNC, if there was something retained product, something retained bits of placenta, or it is a delivery related cause, or it is a succinturita lobe with DNC, it should cure, means bleeding usually stops after DNC, but it is continuing. So that means there is some pathology developing. So what is the pathology occurring or occurring after, after the DNC? It is not DIC. DIC never presents like this. DIC, remember the causes: abruptio placentae, severe preeclampsia, eclampsia, septic abortion, dead fetus, amniotic fluid embolism. History is not suggestive in any of the 5. So I am not going to mark DIC. Lochia duration is still 3 weeks. 3 weeks have crossed and she has heavy bleeding. So I think of gestational trophoblastic neoplasia. It might be choriocarcinoma, although it is rare, because after a full term pregnancy, if any trophoblastic tumor develops after a full term pregnancy, it is choriocarcinoma. So after a full term pregnancy, if any gestational trophoblastic neoplasia develops, it is choriocarcinoma. Always mark your answer choriocarcinoma. First, rule out the other options. It is not DNC because there is no history of PIH, eclampsia, dead fetus, abruptio placentae, amniotic fluid embolism. So that is ruled out. PPH is still 12 weeks, and after DNC, PPH, if has happened, bleeding should stop, but it has not stopped. Lochia never goes beyond 3 weeks. Okay. Usually people say 10 to 14 days is lochia, but extended time if you take 21 days. Okay. In the textbook it is 21 days. So it has already crossed. So it is gestational trophoblastic neoplasia. Next. 25-year-old primary gravida on lithium. What is lithium? Lithium is a drug for bipolar disease or bipolar illness. Okay. And she has psychiatric illness for past 2 years. Most common anomaly in the fetus on lithium during pregnancy is not VSD, PDA or neural tube defect. It is abstinence anomaly. You must have read in pharmacology. Abstinence anomaly occurs. It is associated with lithium. Yes, Dr. Paras, I will explain the Manning score. Manning score is a special ultrasound. Manning score is a special ultrasound where we do NST, amniotic fluid index, fetal tone, fetal breathing movement and gross body movement. Dr. Paras, this has been done for high risk pregnancies. High risk pregnancies. High risk pregnancies are post dated pregnancy, PIH, IUGR, diabetes, chronic hypertension. In these cases, if everything is normal, the radiologist gives score 2 to 2. So normal score is 10 by 10. Okay. If the score is 2 by 10, That means baby is going to develop IUD, immediately take up the patient for cesarean section. Now let us take up this question. 26-year-old female has mechanical valve. So whenever there is a mechanical valve, anticoagulant, patient has to be on anticoagulant. So she is on warfarin, but her pregnancy test is positive. Warfarin is a teratogenic drug. Warfarin is teratogenic drug, so it has to be replaced by heparin. So continue warfarin throughout the pregnancy. No, you can continue heparin throughout the pregnancy. Discontinue all anticonvulsant in pregnancy. Warfarin is contraindicated in pregnancy and lactation. What is the correct answer? The correct answer is replace heparin with warfarin, because first trimester you can't give heparin, you have to give low molecular weight heparin, because heparin do not cross placenta and it is not teratogenic. Okay, so less than 12 weeks it is heparin, because heparin do not cross placenta. 12 to 36 weeks warfarin, 36 weeks to delivery heparin, after delivery warfarin. Now when you have given warfarin, why can't you continue in the 9th month? Because when you give warfarin in the 9th month of pregnancy, it used to do the bleeding tendencies in the neonatal brain. Okay, so this is for the mechanical heart valve. ठीक है. Complication associated with IV bolus injection. Never we use IV bolus oxytocin. We always put it in the drip, or we can give intramuscular bolus. If you give IV bolus straight in the vein, it will cause hypotension, because its action somewhat similar to the ADH. So it is causing hypotension on giving IV. So false statement regarding instrument given in the image. So matter of chance, the image was not, I think it got deleted. I had already put up the image. So this was, you know, like MVA syringe was there, where the electricity facility is not there. There are two valves, and it is done in for, you know, like we can't say MTP when the female is overdue with the periods and termination has to be done to regularize the cycles. Then this MVA syringe has been used. I have been using it, this image in my previous classes, forgot to add in this case, or it is got deleted. It creates a pressure of 650. This is correct. Maximum volume is 30 ml, wrong. Maximum volume is 60 ml. Can be used up till the first trimester of pregnancy, correct. So this syringe, a Carman's cannula is attached. It is a double valve plastic syringe. 60 ml is the capacity. It generates a pressure by 660. Pressure is 660 millimeters of mercury, and it is attached with the Carman's cannula. Next, G4P0A3. This means whenever the female is pregnant, we use the term gravida. Gravida means she is pregnant. P means parity. Parity means number of deliveries, stillbirth and live birth. She is 4th time pregnant and she had 3 abortions. 3 abortions. It should signify you the recurrent pregnancy losses. Let us read further question. 24-year-old female at 22 weeks of pregnancy, that means it is mid-trimester, with a previous history of 3 mid-trimester abortions. Cervical length is 20 mm. So you have already got the hint in the question. Normal cervical length is 25 mm. What could be the most probable cause for her recurrent pregnancy losses? when they have given shortening of cervical length, so it has to be cervical incompetence. Okay, so this is very, very important cause for second trimester abortion. If not treated, it can lead to recurrent second pregnancy losses. Uterine anomalies also cause recurrent abortions. Chromosomal anomalies can cause first trimester abortions. Hormonal imbalance usually causes first trimester abortions. So it is no other than cervical incompetence, and the treatment is cervical encerclage operation. That is McDonald's or Shirodkar. Okay. Now next question. 24-year-old female. So it has to be very, very crisp and to the point revision, because many questions I have kept here so that you can revise most of the question in this limited hours session. So primi gravida, she is having pain. Primi gravida term is used when she is pregnant. Cervix is 1 centimeter dilated, 20% effaced. After 10 hours, the finding is roughly the same. Fetal heart rate is normal. So BP is not mentioned, it appears to be normal. Fetal heart rate is normal and she is in latent phase only. So let it be. So even 10 hours. So please do not mark your answer as emergency cesarean. Is there high blood pressure? Is there abruptio placentae? Is there placenta previa? Is she gone into active labor? So you will not mark cesarean. Do not do ARM at 1 centimeter dilatation when she has gone into active labor. For example, cervical dilatation is 4 to 5 centimeters and there is bulging fetal membranes and it is a high risk pregnancy. Then we do ARM with Cocker's forceps, otherwise not. Start oxytocin. Why should I induce this patient or augment this patient? Because this is just sedation and rest and she will be fine. Okay, so answer is sedation and rest. Now 24-year-old female, 32 weeks of pregnancy, BP is 160 by 116. So it is pre-eclampsia. Nowadays proteinuria is not very, very important criteria into considerations. Her lab finding is significant for increase. So she has high blood pressure and it is severe, increased LFT, liver enzymes, or you can say deranged LFT. There is increased LDH and there is low platelets. The values are not being given to me. Okay, if the platelet count is less than 1 lakh per cubic millimeter, LDH is elevated to more than 60 international units, deranged LFTs, BP is high and peripheral smear shows hemolysis, I am going to mark HELP syndrome in my diagnosis. Fatty liver do not present like this. What is the role of low platelets if there is a fatty liver? Even cholestasis, hepatitis do not present like this. They present with jaundice and serum bilirubin values are not given in this question. So I am going to mark a HELP syndrome. In cases of 10 to 15% cases of severe pre-eclampsia, a complication is HELP syndrome. HELP syndrome. Okay? So management of HELP syndrome is termination of pregnancy. So you should revise HELP syndrome, pre-eclampsia, that is very, very favorite for questions. So it is HELP syndrome. If they have given the findings, that would have been better answer. But none of the other options are fitting. Always try to rule out the answers. Whenever, जब भी कोई आपको long question मिले ऑब्स गाइनी में, always try to find out the hints in the question and then rule out one option or the other and then mark your answer. So always read 4 questions first. Fine, 4 options and then you mark. So welcome you all, those who have joined recently, Dr. Mukesh, Dr. Ankit, Dr. Humble and my cutie hubby buddies, all those I don't know exact your names. Now 16-year-old female presents with cyclical pain every month, primary amenorrhea. Cyclical pain with primary amenorrhea, secondary sexual characters are normal. That means breast is normal, she has primary amenorrhea. Cyclical pain. Cyclical pain का मतलब क्या होता है? Every month she has pain abdomen. Every month pain किस में होता है? Dysmenorrhea में. इसका मतलब ovarian function is normal. Because breast is normal, so ovarian function is normal. What is the hormone responsible for breast development is estrogen. ठीक है? Then axillary hair, pubic hair is also normal. ठीक है? On examination there is a bluish membrane bulging. So are you going to do hormonal profile? No. Hormonal profile वहाँ करते हैं जहाँ हम टर्नर syndrome suspect कर रहे हैं. So this is not Turner because secondary sexual characters are normal, breast is normal, axillary pubic hair is normal. There is a bluish membrane bulging on local examination. Karyotype में तो इसमें normal ही आने वाला है क्योंकि जब ovary normal है तो karyotype हमेशा ही normal रहेगा. लेप्रोस्कोपी कभी भी अनमैरिड फीमेल में कभी भी नहीं करते. क्यों हम इन्वेजिव प्रोसीजर करें? सो हेयर नो अदर देन अल्ट्रासाउंड बिकॉज दिस इज व्हाट इज imperforate hymen. Imperforate hymen. But I have already taught in my sessions that genitourinary anomalies can be associated. So number one, it will confirm your diagnosis that on ultrasound uterus, cervix, fallopian tube, ovaries are present. Okay, plus any renal anomaly if present, you can always rule out by doing the ultrasound. So answer is imperforate hymen. So you will get an ultrasound done to check uterus, cervix, fallopian tube. And what is the treatment for this? Treatment for this is cruciate incision and drainage. Okay, so why ultrasound you are doing? Number one, to confirm that uterus, cervix, fallopian tube and ovary are present. Number two, why not karyotyping? Because karyotyping is usually most of the time is not our answer. With ultrasound you can rule out other genitourinary anomalies if present. Now what is the treatment for this imperforate hymen? Many times an image based question is given in NEET PG, INI CET and FMGE exam. They have asked in 2020, they have repeated in 2021. So this is very important question from primary amenorrhea. Either they can ask you question like a statement I have given you. How to rule out the answers I have told you. Please student, it is a request, do not jump on to karyotyping. जब भी ovarian function normal लिखा है तो karyotyping normal ही होगा. Okay, so here non-invasive, safest and best investigation, you should go for an ultrasound. Okay, next, I hope your concepts for obs gynae has been building and you are marking the correct answer. So it is again build up the confidence plus you are revising the topic. मैं ऑब्स भी डिस्कस कर रही हूँ, गायनी भी डिस्कस कर रही हूँ, नए टॉपिक्स भी डिस्कस कर रही हूँ, नए क्वेश्चंस भी हैं और कुछ रिपीटेड क्वेश्चंस आते हैं वो भी मैंने इसमें डाल दिए हैं. ठीक है, सो स्मार्टली आई हैव एडेड पीजी क्वेश्चंस एज वेल विच इज़ इंपॉर्टेंट विच कैन कम इन द FMG एग्जाम एज वेल. So in a female undergone DNC for missed abortion, after that she developed secondary amenorrhea. DNC के बाद secondary amenorrhea and FSH level is normal. Normal FSH is 5 to 20 international units. What is your answer? ये question हमेशा से this was a PG question. ठीक है, this was a favorite question of AIMS PG, but it has become a favorite question of FMG exam. Okay, and this has been asked in INI CET exam as well. Okay, JIPMER and all that. So FSH normal है, secondary amenorrhea after a DNC. इसका मतलब इतना vigorous curettage कर दिया है that there is formation of synechia. So it is no other than Asherman syndrome. Okay, what is the confirmatory investigation for this? So next investigation you can do HSG or you can direct go for a gold standard investigation, gold standard investigation is hysteroscopy, because it will be diagnostic as well as you can treat your patient by hysteroscopic guided adhesiolysis. Okay, I hope it's clear to all of you. Asherman syndrome is correct answer. Now, I have already asked in my live session face to face in the batch, but again I want you to repeat this because I want कि आप चारों टाइप के कैरियोटाइप करें. तो मैंने इसको नंबर दे दिए हैं A, B, C and D. So identify. अब कैरियोटाइप नंबर A क्या है? What is the कैरियोटाइप? वैसे आपको एरो मार्क करा हुआ नहीं मिलेगा. What's your answers? Write down quickly. I have written A, B, C, D. What's your answer? Okay, this is trisomy 21, that is Downs. What is B? What is B? Trisomy 18, that is Edward syndrome. What is C? What is C? What is the third one? C. No, it is not Turner. This is trisomy 13. Trisomy 13 is Patau syndrome. And what is D? Fourth option. D is 1X is absent. So it is 45XO Turner syndrome. So first one was trisomy 21 Downs. Second one was trisomy 18 Edward. Trisomy 13 was Patau and fourth one is monosomy. इन सबको क्या बोलते हैं? Aneuploidy. Whenever there is defect in the chromosome number, either one chromosome extra or one chromosome absent, we call it as aneuploidy. And aneuploidy screening I have already discussed in my sessions. Okay. Now next, 19-year-old girl presented with primary amenorrhea, breast normal, axillary pubic hair normal, absent uterus. It has been a very favorite question. Uterus absent है, primary amenorrhea है, breast normal, axillary hair, pubic hair normal. Breast normal, that means body में estrogen है. Estrogen का मतलब है gonad is ovary. Okay, gonad is ovary, karyotyping is 46XX. And if axillary pubic hair is present, that means androgen is also present. So it cannot be androgen insensitivity syndrome because axillary pubic hair will be absent in testicular feminization syndrome. Turner syndrome, breast development will not be there. Sphere syndrome is 47XY with undescended testes with uterus, cervix, fallopian tube and vagina. So it is Mullerian agenesis 46XX. Uterus absent and ovary present. Okay. Mullerian agenesis, uterus absent and ovary present. Next question, 30-year-old female presented with secondary amenorrhea, urine pregnancy test was done negative. मतलब female has secondary amenorrhea. Whenever a patient comes with secondary amenorrhea, always do urine pregnancy test. Urine pregnancy test positive, that it is pregnancy. If it is negative, give progesterone challenge test. Progesterone challenge test. You give any progesterone like medroxyprogesterone acetate 10 mg for 5 days and stop. Watch for withdrawal bleeding. Bleeding present. That means this is an ovulation polycystic ovarian disease. Okay. क्योंकि polycystic ovarian disease में no ovulation, no progesterone. There is only estrogen, so thick endometrium has been formed. When you give progesterone, there is secretory changes. When you stop progesterone, there is withdrawal bleeding. So that is called as positive progesterone challenge test. And if there is a withdrawal bleeding seen, that means it is an ovulation PCOD. If there is no withdrawal bleeding, then you give estrogen progesterone. It can be premature ovarian failure, it can be pituitary or hypothalamic disorders. Okay, if I explain it will become too detailed, but just understand. Secondary amenorrhea में सबसे पहले urine pregnancy test करते हैं, rule out pregnancy. Then next step is you give progesterone for, that is called as progesterone challenge, for 5 days and then stop. She will have withdrawal bleeding. इसका मतलब anovulation, progesterone deficiency, polycystic ovarian disease. Okay, if withdrawal bleeding is absent, it can be hypothalamic disorder, pituitary disorder, or it can be like Asherman syndrome if bleeding is absent. Fine. Next, so this is PCOS. There is something in the framing of question. आप इसको यहीं पे करिए, likely cause. इस question को यहाँ से हटा दीजिए. Likely cause. बस आपको यही बताना है इस question में. What is the likely cause if withdrawal bleeding is present? Otherwise, मैंने इसको progesterone withdrawal bleeding के हिसाब से डिस्कस करा है. इसमें हम ऐसे कर लेते हैं, ब्लीडिंग प्रेजेंट ईस्ट्रोजन प्रोजेस्ट्रॉन नहीं करते. अगर ईस्ट्रोजन प्रोजेस्ट्रॉन करेंगे तो उसमें प्रीमेच्योर ओवेरियन फेलियर, पिट्यूटरी एडिनोमा एंड हाइपोथैलेमिक डिसऑर्डर्स, ये तीनों आ जाएंगे. ठीक है. अगर मैंने इसमें, अगेन आई रिपीट, इफ़ यू गिव प्रोजेस्ट्रॉन एंड देर इज़ अ विड्रॉल ब्लीडिंग, देन इट इज़ PCOD. If there is no bleeding, then you give estrogen and progesterone. Then cause can be premature ovarian failure, pituitary or hypothalamic. ठीक है. If I rub this question and I take the original question, then also I will discuss. लेकिन most importantly PCOD they ask, which I have explained. After progesterone there is bleeding, that is PCOD. Okay. Now I will discuss with the original question which I have framed. You have given progesterone, there is no bleeding. Okay. Secondary amenorrhea, you have done urine pregnancy test, it is negative. You have given progesterone challenge test, negative. Then you have given estrogen plus progesterone, bleeding. PCOD में progesterone challenge पे ही bleeding आ जाता है. So all three are the correct ones. So what is the answer in this question? What answer do you get it in this question? PCOD has been ruled out because withdrawal bleeding will be present after you have given progesterone. Okay. 28-year-old female, history of foul smelling vaginal discharge, saline microscopy has been showing this. What do you see in this saline microscopy? What do you see in the saline microscopy? saline microscopy में आपको क्या दिख रहा है? डॉक्टर एन कुमार, डॉक्टर दिव्या, डॉक्टर हम्बल, डॉक्टर देसी बॉयज, डॉक्टर विनीत, डॉक्टर मुकेश, डॉक्टर अंकित, डॉक्टर मनन. What is your answer? Yes, cute buddies, correct. This is clue cells. Clue cells is seen in bacterial vaginosis. So you should remember Amsel's criteria, foul smelling vaginal discharge. So this is bacterial vaginosis. There is no itching and it is not STD. Drug of choice is metronidazole. Okay, so you remember Amsel's criteria which has been asked in FMGE 2020 exam. Okay, next, hormonal profile in a menopausal lady. Hormonal profile menopausal, that means ovarian function has been down. So there is no ovulation, estrogen, progesterone is down. So there is no negative feedback at the pituitary. Pituitary secretes high FSH and high LH. So the answer is high FSH and high LH. Again 2020 FMG exam question. Okay. Now which of the following peak is responsible for ovulation? Peak C, peak B, peak D, peak A. Peak B is LH surge. So peak B is responsible. Peak B is LH surge. So peak B is responsible for ovulation, and LH is the hormone that acts on the dominant follicle and bring out its rupture. Ovum is released and formation of corpus luteum take place. So this is peak B. Peak B is for LH. Peak B is for LH. Okay. Next, pregnant female came with pigmentation of the face. What is this? This is chloasma of pregnancy. Hormone responsible for chloasma is estrogen. Okay. Hormone responsible, this is again an FMG question. Hormone responsible for chloasma is estrogen. According to WHO, maternal deaths, more than 24 hours, maternal death within 6 weeks after delivery, maternal death within 2 weeks of delivery. Little bit, this is a PSM question, and this is preventive obstetrics. Okay. So what is the correct answer? Let me show you the definition. It is annual deaths of the mother and within 42 days of termination of pregnancy, irrespective of duration. That means within 6 weeks of termination of pregnancy, if the death occurs, that is what is a definition of maternal death. Next, before laparoscopic surgery, what advice should be given by the surgeons? मैंने इसमें लिख ही दिया है, आजकल NPO 6 hours बोलते हैं, तो it is on table removal of hair by razor और part preparation is done on table. पहले से हम part preparation नहीं करते. Jet when I was doing post graduation, that time पहले से labor room में part preparation करके भेजते थे. Nowadays correct recommendations is part preparation is done or like cleaning by razor, that is preparing the area for surgery. It is done on table, surgery table. So NPO nilparolally 6 hours semi-solid and liquid diet, NPO 2 hours plain fluid. 55-year-old female found to be diagnosed with cancer cervix stage 2-3. हमेशा याद रखिए stage 1 का treatment है surgery and stage 2 2A2 onwards it is concurrent chemo radiation. So this question has been recently asked in FMG exam. उसमें सिर्फ स्टेज का ट्रीटमेंट पूछा था, एडवांस स्टेज, स्टेज 3 का. सो इट इज कंकरेंट कीमो रेडिएशन. सो स्टेज 1B3, स्टेज 2A2, स्टेज 3, स्टेज 4, स्टेज 2B, इन सब स्टेजेस में कंकरेंट कीमो रेडिएशन. बाकी अर्ली स्टेजेस स्टेज 1A1, A2, B1, B2 and 2A1 is surgery. Rest all the stages it is concurrent chemo radiation. Endometrial cancer where there is vaginal extension, then it is stage 3B. Please do revise the FIGO staging for cancer cervix, cancer endometrium, and stage wise treatment is also important nowadays. Fine. About corpus cancer syndrome, which of the following is false? Diabetes, hypertension, CA breast. Multiparity is not a risk factor, I have just discussed. It is nulliparity which is a risk factor. Nulliparity is a risk factor. Investigation of choice in 55-year-old female post-menopausal bleeding she has presented. Whenever a female comes with post-menopausal bleeding, first investigation you should mark is transvaginal scan and you check endometrial thickness. Cutoff value for endometrial thickness is less than 4 mm. Just do the follow-up. If it is more than 4 mm, then what you do is you go for endometrial sampling using a pipple or carbon cannula and send the sample for histopath to rule out endometrial hyperplasia or endometrial cancer. Fine. So this is something which is important. Postmenopausal bleeding में फर्स्ट इन्वेस्टिगेशन क्या है? हमेशा ट्रांसवेजाइनल स्कैन मार्क करना है, ठीक है. एंड फ्रैक्शनल क्यूरेटाज आपकी गोल्ड स्टैंडर्ड है. पैप्समियर आप करते हैं, बट पैप्समियर इज मोर इम्पॉर्टेंट टेस्ट फॉर कैंसर सर्विक्स, ओके, which is not a test for ovulation. Progesterone at day 14, no. Secretory endometrium on endometrial biopsy, rise in basal body temperature. This is all correct. हम rise in BBT भी करते हैं, cervical mucus भी करते हैं, हालांकि आजकल इनकी वैल्यू कम हो गई है. और प्री menstrual endometrial biopsy. These are the tests for ovulation. But serum progesterone is done on day 21 of the cycle. Corpus luteum secretes which of the following hormone? Estrogen, progesterone, inhibin A and relaxin. Inhibin B is secreted by granulosa cells, ठीक है, and AMH is being secreted by granulosa cells. Estrogen is secreted by granulosa cells, E2, that is estradiol, ठीक है. So inhibin B by granulosa cells. Fine. Contraceptive of choice, spacing contraceptive between two pregnancies at least 3 years gap is always a copper T, okay, is always a copper T. What is this maneuver? This is first pollic grip, first fundal grip. This is second lateral grip. This is third pollic grip. This is fourth pelvic grip. So you apply all these grips when you are doing per abdomen examination to check for lie and presentation. This is called as Leopold's maneuver. So even if they are giving one grip, you should be able to know it is not external cephalic version, Dr. Nitin, Dr. N. Kumar. This is Leopold's maneuver. 4 grips are applied: fundal, lateral, pollic and pelvic to describe lie and presentation. So it is Leopold's maneuver. Okay, it is Leopold's maneuver. Fine. So this is partogram. First is maternal information, second is fetal well-being, third is labor progress, fourth is medications, and fifth is maternal information. So I had already been discussing this. Okay, this sessions is very crisp. So what do you plot is alert line in WHO modified partogram. Latent phase not plotted, only active stage. So plotting starts from 4 centimeters of cervical dilatation. There is alert line, action line. No, it is not external podalic or cephalic version, because you can see, doctor, there are grips being applied. So this is Leopold's maneuver. External cephalic podalic version में इस तरह की grips नहीं होती, and this first, second, third, fourth maneuver is not written in that case. Please do not get confused. Dr. Anil has been writing and he has made a correction. This is Leopold's maneuver. So this is partogram, and this baby has been delivered and it was 2.8 kg baby. This is copper T 380A, government supply. It is longest acting IUCD. Effective period is 10 years and failure rate is 0.6 per 100 women year. Okay. Identify the type of prolapse. What type of prolapse is there in this question? You can see in this question very carefully, because nowadays even in FMG exam questions are asked on genital prolapse like this. You can see this is the uterus, this is the urinary bladder, this posterior is the rectum. So if you see very carefully, uterus is deviated from its anatomical position. So this is uterine prolapse, and it is, if prolapse is occurring within the vagina, you can see on per speculum examination, this is first degree cervical descent. Okay, diagnosis is first degree cervical descent. 50-year-old female, third degree cervical descent, cystocele, rectocele. What is the surgery? I am just revising here. So it is vaginal hysterectomy with pelvic floor repair. 50-year, cystocele, cervical descent and rectocele. Ring pessary is prolapse occurring in pregnant lady. Fothergill operation is multiparous lady, genital prolapse, family complete. Sling operation is for nulliparous prolapse. Okay, sling operation is for nulliparous prolapse. Okay. Latest treatment in case of acute PID according to CDC criteria is ceftriaxone, that will cover gonococcus. Doxycycline will cover chlamydia. Metronidazole will cover trichomoniasis and bacterial vaginosis. So this is the latest treatment for acute PID OPD basis. So hope this session was useful to you. So keep revising the subject well, and whatever are the high yield topics, always disorders of menstruation, contraception, infertility, ectopic pregnancy, in gynae cancer, trophoblastic tumors, cancer cervix. Okay, and nowadays they are asking genital prolapse. Apart from that, PID is important, NACO kits are important, color code kits, then vaginal discharge is important. In obstetrics, they can ask you from anywhere, but mostly their pattern has become very clinical. So all the best to you. Okay, hope this session was useful to you and you have been able to revise so many topics with me. So that's all. Thank you so much, Dr. Paras, Dr. Anil, okay, for your wonderful words for this session. Thank you so much. All the best for your exam.